So if I could just get you to introduce yourselves. Sarah, I'll start with you, and then Daryl and Joanne. A little bit about yourselves and your role.
Sure. Thanks so much, Kath. So my name's Sarah Newberry. I'm a rural generalist family physician. I've been here in the community of Marathon for 25 years. And as a physician group, we partly fund the community connector role that Brett is currently in. I'll pass it on.
Daryl?
Great. Hi there. Daryl Skwarczynski. I'm the Chief Administrative Officer for the town of Marathon, probably better known as the town manager in other places. I've been lucky to be born and raised in Marathon and come back into this role. I've been part of this group for the last 8 years. And it's a great model, and hopefully we can share what we've learned in our time here.
Thank you, Daryl. Joanne.
Hi, everybody. I'm Joanne Berube. I'm the Executive Director for Marathon Family Health Team and the Director for the Marathon Physician Associate Group. I have worked with both organizations for almost 23 years, and we are co-located at one clinic location, and we're known in the community as the Marathon Family Health Team. So I'm primarily responsible for operations management and for the executive director role in terms of strategic planning and governance for both organizations. And it's a job I've really enjoyed for the past 23 years and love being part of the team and the physician group.
Yeah, I'm Matt Brown. I'm the CEO of the North Superior Healthcare Group, and we are a collection of 2 hospitals, a long-term care home, and are operators of Marathon Senior Supportive Housing Corporation, which is our seniors apartment complex just across the parking lot from us. I haven't been around as long as Joanne or Sarah, but in my current role since 2013 and in the organization since 2006. So 15 long years already. That's really scary. And we've been in this, I've been in this group of recruiters and supporters since that was 2010, I think it was, right? Under their former CEO, Paul Parody. So long involvement in our journey, our successful journey.
Okay. So now I'm just going to ask each of you to briefly present on the kind of support your organisation has provided to support Brett's role, and the reasons for supporting the position both initially and ongoingly. So Sarah, we might jump in with you.
Yeah, sure. So as a physician group, we've just seen huge value in Brett's role. He works with us really quite side by side, day to day, and we provide a portion of the funding that goes towards his income and just have seen significant value. That's been a really worthwhile investment for us. In the context of our day-to-day work, Brett helps us scheduling locums. He helps coordinate learners, welcomes them to the community, welcomes locums to the community, checks in with each of us from a retention standpoint, and also has been really key to welcoming new grads and new clinicians into practice. From the standpoint of this group, the 4 of us on the screen now, we are the governance group of Brett's role, but the day-to-day operations elements of his role, as far as it pertains to physician workforce, really he liaises directly with the physicians around his day-to-day work.
Okay, thank you. And your contribution. So I'll ask each of you the financial contribution.
Yeah, so it varies a little bit year to year. I think this year we're contributing $5,000 or $6,000 to his role.
Well, to build off what Sarah stated, I think as a municipality, our take on this is a little different in the sense that, we look at it from a very holistic perspective, and, we have great community partnerships. Certainly this is an excellent example of that, but, as part of our corporate strategic plan, we know that, for us to have a community that, is livable and people want to live in, we need to connect the dots with healthcare, with socioeconomics, with recreation. None of those are standalone on their own. So we see great value in a group like this. And, historically, and Sarah didn't mention it, but, it was back in 2010 when we had some physicians that were leaving the community to pursue opportunities elsewhere, where this concept kind of really started to formalize itself and actually create the group that exists, and to hire the recruiter. And we were lucky enough to have Brett, who was in a role as a golf pro at the time. So that's where I first got to meet Brett, because he worked for me in that role. But that's really where this started to formalize itself. And in 2011, the committee was established, and here we are, 10 years later. And I think, I would dare say probably one of the best models, maybe, across the globe, in terms of our abilities to attract not just physicians. Now we're into healthcare professionals, but I think a lot of it is a collection of the commitment to Marathon, but also the synergies and the respect we have for each other as professionals in the community. We work very well together, and the end goal is always about the community and not one single organization. In terms of the town of Marathon's contribution, this current council that I've been with for 8 years is very supportive of this group. We started out with $15,000 a year back in 2011. And now we provide $10,000 a year. So we've given approximately $125,000 since the inception of the group over its lifespan. And we offer other in-kind donations to the group as well. We own 2 homes in Marathon that we contribute and donate for the use of physicians like locums when they're in Marathon, and maintain those in our operating budget on a yearly basis. And we also offer things like free recreation when we have healthcare professionals visiting or staying in the community, so they can experience some of the great facilities that we have. So I know this is a model that I think works extremely well, and I think it works extremely well because it has a lot of key supporters, but it also has, as you see on the call tonight, a group that's very committed to it to see its success.
Thank you so much, Daryl. Joanne, we'll jump to you now.
Yes, so I can echo a couple of Sarah's and Daryl's comments. So support, I'll start with support first. Marathon Family Health Team contributes, as well as the physician associate group. I think the physicians originally contributed around $5,000 annually. We increased that to $6,000, of which the Family Health Team organization took a portion of $2,000. And the remaining $4,000 comes directly from the physician associates. So that has been an ongoing contribution annually since, as Daryl mentioned, 2010. We also, as a clinic, provide in-kind donations of desk and office space, use of computers, printers, desks, telephones, cell phone, and general office supplies. Brett is a member of our team, and he works collaboratively with and is supported by our administrative staff and clinical team, in particular our booking and scheduling staff, and those are all in-kind donations as well. And the FIT was responsible initially for drafting Brett's contract, and as well as defining the expected deliverables for his role in collaboration with our community partners and our physician group. So the reason initially why we supported the development of the position was, as Daryl had mentioned, in 2010, we had been enjoying a complement of 9 family physicians in community for about 15 years. That was pretty stable, but we were faced with 3 of them leaving in that fiscal year. And so during that 15-year term, we'd been focused more on sort of short-term locum placement for locum physicians to our community. And we hadn't really been concerned, because we had the stable physician base, of replacement, a replacement plan or retention plan. So we hadn't really considered either of those 2 things. With the announcement of the 3 physicians leaving, we recognized that if we were not successful with recruitment efforts for replacement, that there would be a significant change to the delivery of primary and acute healthcare services for our catchment area that could potentially negatively impact our community hospital and primary healthcare team. We also recognize that none of us really had the time. We have a busy clinic, we have a large catchment area, to really dedicate efforts fully to designing and implementing a recruitment retention plan. So we needed help, and that help had to come from our community partners. Once the plan would be launched, we would need a primary contact person for physicians seeking placement. And we also recognized that retention of those physicians being left behind, if I can use that term, was also at risk, because as other physicians left, until we could find a replacement physician, there would be an increased burden on them, and to provide care both at the hospital and at the clinic, which posed the risk that they could also start to leave as well. So we could actually lose a lot more than just 3 physicians that we knew about. We could lose 4 or 5 or even more. So it was really, concerning to us and a risk to us that this could be the start of something worse. So ongoingly, we continue to support this role because, things are always changing. Life happens. You never know when someone is going to leave or the reasons they choose to leave. And it's important to keep up to date with what is happening in the province and country to know how it may affect remote, isolated communities such as ours and the healthcare professionals that we're trying to secure to provide services. So in 2010, we knew that family physicians were caring for more patients than in previous years. Family physicians in Ontario were getting older. The population in Ontario was getting older, increasing the demand for primary care services for those who are aging. Graduates were more interested in working at venues that offered zero overhead attachment, such as locum or ER work. So big money, no overhead, faster reduction of personal debt. Lots of graduates were women who were choosing to start families and therefore not going into practice full-time as their male counterparts would do upon graduation. Ontario had predicted a decrease in physician population ratio until 2021, which is now this year. The competition was incredibly fierce, as other locations might seem more desirable to potential recruits than ours, and an increasing lack of specialist support is making rural practice less attractive. The impact of these facts was very significant. The presence of effective healthcare services in a community is an element of infrastructure without which business and industry struggle to grow, as Daryl's noted. Lack of physicians and hospital services creates a barrier to professionals choosing to relocate to a community. Lack of local physicians forces many senior citizens to move from their homes in order to access physicians elsewhere. Workers and young families will choose to settle where they can access care. Physicians are generally major employers in our community, and physicians create significant economic spin-off, particularly for small remote communities. So it's important to have somebody on this project from the recruitment perspective to keep our supply of physician professionals and allied healthcare professionals keep it sustainable and keep it to the level that we were used to having. But it's also equally important to retain the health professionals and physicians that we already did have. So the retention plan needed to happen at this time as well, so that they would know they were needed and very valued and supported. So, this is why it's important from our organization perspective and from a community perspective to have a person dedicated to the recruitment and retention of our physicians and of the allied healthcare professionals in our community.
All right. Thank you so much, Joanne. Adam, we'll throw to you now.
Sure. Joanne stole all my good ideas, but that's great. Similar to
you can reinforce them.
Yeah, I'll do my best. Similar to the other ideas presented so far, the hospital simply plays a role. We're part of a community and quite obviously a big part of a physician's community from more than just a work perspective, actually. But I think our primary role as a hospital is to provide an environment that's inviting. So at NOSH, we put a lot of effort and money into making sure our building is up to snuff and our equipment are up to snuff. Above and beyond that, we, similar to the town, provide, I believe it's $10,000 or $12,000 currently. It does fluctuate from year to year. And at the beginning of the project, 10 years ago now, it was $15,000. We also provide a minor amount of space, a minor amount of clerical support. Besides that formal role, though, in small communities, there's a reality of your small communities, and there's not a lot of professionals in our communities. So, a large part of our professional community is on this screen right now. And so I think we all recognize the role to be part of a social circle if required and demanded or needed by new and existing professionals like physicians. And there's some funny ideas, and Brett is really good at this, but I've lent out my four-wheeler. Is that a term that you understand, Kath? Your quad, your off-road vehicle, many times. I've supported fishing, although Daryl would say I'm not a very good fisherman. But just small parts of the social fabric to allow our locums and new recruits and existing physicians to be part of our community and enjoy what Marathon or Terrace Bay, as my other community, has to offer. And I don't think it's been mentioned yet, but what's really important is we don't sell Marathon. That's not Brett's role. We match Marathon. So somebody who enjoys going to the opera every Saturday is not going to come to Marathon. You really need to enjoy the outdoors. You need to be comfortable with yourself, comfortable in small, relatively isolated environments. And that's what we try to find, is those people that are going to enjoy our nature and also enjoy the environment that the physicians and Joanne have created in the clinic, right? So it's a very collaborative environment. We do and have to, in most cases, have to work together with other organizations. And Sarah can explain the consensus-based environment in the clinic much better than I can. But if you're not in a headspace where you can work towards consensus and you're not going to be the lone wolf boss, this is not the place for you. Terrace Bay, on the other hand, might be. And so the culture in Terrace Bay is very different than the culture in Marathon. And that's not good or bad, it's just different. And we worked hard to make sure that we're putting or attempting to place our doctors in the environment where they will succeed. One of the other things that I personally and NOSH, I think, generally can provide is perspective. And we've seen instances where recruitment has not gone well. And I think of our neighbors to the north of us, and I'll just say it because we're in a closed environment, but Geraldton District Hospital has not gone well since about 2010. So Geraldton had, was it 6 that went at the same time, Sarah? 5 or 6 physicians that went at the same time. And they had a nice, tidy group of 7 physicians up there for quite a few years, and everybody left in one shot. And despite, urging, prompting, suggesting, to develop an environment like we've established in Marathon and Terrace Bay, where it's a community-led initiative and co-funded and co-supported, for whatever reason, Geraldton has not accepted that model and have not been successful. They continue to be locum dependent. I think they might have a doctor and a half for a community that's actually larger than Marathon. So we've unfortunately learned from other people's mistakes as well.
Okay. Thank you so much, Adam. I just have one Q&A or question around the governance. What does that, how do you manage the governance? How often do you meet, and what are the demands on your time for that?
So I think I started to touch on this in my comments, that I think, and I think Adam has just alluded to it too, we're a very collaborative group, and I think over time have developed a high trust environment. And Brett is somebody who was known to us through his role with the town, and just as a good citizen of Marathon. So I think our governance model continues to operate in a high trust environment. Not all of the funders are here on the call. We have industry funders who provide the funding and say, what's happening seems good, continue to make it work, essentially. So we meet periodically, sort of on an as needed basis. I think it's not more than quarterly currently. Brett provides us with updates. The physicians do most of the day-to-day scheduling, coordinating, identifying where we need Brett to step in to support us, to welcome physicians and learners. I think there are staff at the hospital who connect with Brett around the recruitment of physios and nurses and do some of that day-to-day work with him. But the governance piece is really really very much at the governance level. We review the budget and some of his deliverables. We don't track his hours. We track basically his success. And that's sort of the model that we're operating under. I don't know, Adam, maybe I'll turn it to you to see if there's anything that you want to add.
Yeah, the theme is that, the theme is trust. And I believe we do have an official terms of reference somewhere that has a voting model and all that, but I'm not sure that we've ever used it. All of us, as you can now tell, are long-term citizens to Marathon and have a high level of personal and professional trust. And I don't think there's been a decision that we've had to make where we've had to vote yet, including things that can be contentious like budgets, right? And yeah, trust is the key. And even with formal terms of references or contracts or whatever, it doesn't matter if there's not trust. Those contracts fall apart as well. So,
okay, thank you. And what about Daryl? Anything to add?
I think a key, and it follows the theme that Adam and Sarah have presented, is, you know, and Joanne as well, is we're all very like-minded in that you know, we participate and have the support of our organizations for participating, you know, with the end goal of supporting Marathon, right? It's not about the family health team getting credit or the physicians group or NOSH or the town. It's, you know, we want Marathon, you know, under, you know, this scenario that we have, to be as successful as possible. And, you know, as a collective group, if, you know, if we're able to achieve that, then the ultimate beneficiaries are the residents of Marathon. And that really, you know, since 2010 has been the end goal, right? It's been, you know, what can we do collectively, not individually? And I think, you know, Sarah indicated, or Adam, that, you know, industry, and in our case, Barrick Gold has, you know, been a great contributor to the project. Although they don't sit on the committee, their dollars are there every year. And we know if we ran into a challenge financially, that they, you know, they would be there to listen and support us as well. So the goal has never necessarily been about, I would say, governance. It's been, and Sarah, I like the term success. It's about, you know, collectively sharing in that success. And when we achieve that, you know, Marathon's better for it.
Thank you. Joanne.
Yeah, probably the only thing I would add to what Sarah, Daryl, and Adam's already stated is that there is a piece around connecting with Brett more than at our formal quarterly meetings as a group. I think operationally, day-to-day challenges present for him, and he needs a touch point. And so I would say that in those instances, he would reach out to either myself or one of the physicians, just to connect with them and gain some insight or advice in order to move forward with whatever challenges he might be facing. It doesn't happen very often, but I do check in with him once a month, sort of informally. How are you doing? How are things looking for, you know, locum recruits, for scheduling, any challenges with staff? Any challenges administratively? Is there anything you need from me from a systems perspective to make things easier, just to make sure that he's doing well, you know, because often we think about the wellness of, you know, in terms of his role, he's there to be that ambassador for our community and to ensure that our existing staff feel valued and appreciated and also recruit. But sometimes, you know, it's just nice to check in with the individual to make sure that they're doing well too. And so informally, Brett and I will meet probably about once a month through the winter, through the summer, every other month, just to connect and make sure that things are going well.
Okay, thank you so much.